Ellingson. I'm one of the ER residents here, and I'm going to talk about care of the critically ill obese patient. I picked this topic because I think it's relevant to all of our practices. We're seeing a growing number of obesity. It's going to become more and more prevalent throughout the coming decades. So some of the objectives off the top, I'm going to go through some of the physiologic changes that occur in obesity, identify factors that are important in caring for these patients, and some of the challenges that we face. So to kind of start off with a case, this is a 45-year-old male brought in by medics after an MBC, blood pressure 80/40, tachycardic in the 130s, hypnic in the 30s, doctor stats 75% on room air. He is morbidly obese with a BMI of 45 and has no IV access. A very abbreviated physical exam, agitated and combative. Lung sounds are hard to appreciate, given his body habitus. Belly's obese, has some tenderness, and the rest of his exam is atraumatic. So as we go through this topic, some things to think about are what are your priorities in managing this case, and what are the challenges in this specific patient compared to a patient with a normal BMI. Go through some demographics. About 60% of our population is overweight, 30% is considered obese. We often use BMI as an indicator for obesity, which is weight in kilograms over height in meters squared. It's not the best indicator. It doesn't take into consideration percent body fat or muscle mass, but it is often used. Some BMI ranges you can read below. Essentially normal is less than 25, and once you get above 30, you're into the obese range. These are some pictures from the CDC website, and they essentially are looking at the percentage of the population in each state with a BMI over 30. So you can see in 1985, the light blue is 10 to 14%. So Minnesota is less than 10% of the state has a BMI over 30. And then fast forward to the year 2000, add a few more colors to the graph. We're now into the tan, which is 20 to 24%, and Minnesota is in the 15 to 19% range. And then fast forward to 2010, another 10 years, and we have dark red in the south, which is greater than 30% of the state. Minnesota is now in the 20 to 24 range. It's important to note that we're still less obese than Iowa and Wisconsin. So some of the challenges that we face in obesity, a number of things to consider. We have monitoring challenges. Blood pressure cuffs are often very inaccurate, and we may need to do more invasive lines, place an arterial line, place central lines just to get a sense of volume status. There's some evaluation difficulties, like I said before. In very obese patients, may not even be able to really appreciate lung sounds, and trying to examine an obese belly can be very technically challenging. We'll talk more about airway management. Vascular access is difficult, and then some procedural challenges, nutritional issues for the ICU, nursing care, and pharmacologic. So going through some physiology, focusing on the respiratory system here. Obese patients have marked reduction in their lung volumes and have more of a restrictive pulmonary pattern. Looking at this lung graph here from medical school, essentially all of their lung volumes are diminished, and the FRC approaches the closing capacity of the small airways. And so what that means is that they're at a higher risk of developing atelectasis, leading to intrapulmonary shunting and hypoxemia. Furthermore, their lung mechanics are significantly altered. Imagine trying to breathe with weights on your chest. Obviously would make it much more harder to breathe, decrease chest wall compliance, increase work of breathing, and then due to the weight on the abdomen, raising the diaphragm into the thorax, they have even more restrictive lung volumes. They have an increased VQ mismatch. Upper lungs have better aeration and lower lungs have better perfusion. And then they develop more respiratory muscle insufficiency, working harder to breathe, consuming more oxygen, and their respiratory muscles fatigue at a more rapid rate. From a cardiovascular standpoint, these patients often have increased blood volume and cardiac output because they're perfusing and supplying more oxygen to more body tissues. And this leads to structural changes of the heart, functional changes of the heart. From the restrictive pulmonary process, they end up developing pulmonary hypertension, which leads to right ventricular hypertrophy. And then from elevated blood pressures and increased afterload, they develop left ventricular hypertrophy. And so these patients often have more of a diastolic dysfunction. This graph on the right is from the Framingham study. This is longitudinal. This is over the course of 20 years here, and you can see the incidence of CHF in women here and men here, and essentially obesity has a higher risk of CHF compared to the non-obese. So just to kind of sum up some of the main changes, they have this restrictive pulmonary pattern leading to diastolic dysfunction and heart failure. And what that really means is they have really crappy cardiopulmonary reserve. And so when we have a patient who appears relatively stable in the ED or the ICU, we have to remember that they have a higher risk of decompensating pretty quickly. And so keeping a close eye on them, monitoring them, getting early access. So moving on to airway management. What makes an airway challenging to manage? Typically, there's anatomic and physiologic changes that really affect our airway. Poor pulmonary reserve, these patients are at high risk of decompensating and desaturating very fast. This is a picture of Sean Boley from his first year of med school, or second year?
It was first, yeah.
First year, okay. And so you can see from the picture he's got very distorted anatomy. So they got a short, thick neck, small mouth, a lot of redundant oropharyngeal tissue, although he does have a big mouth, and limited neck mobility. And all these factors make it a lot harder to intubate, and higher Malapati score. Essentially, this is the Malapati classification here. Class 4 is an indicator of a harder intubation. So when we're setting up to intubate, ultimately our goal is to get the tube in the trachea, maximize our success. And in these patients, we have to be a little more cognizant of failure, thinking through our backup devices and having a few ready. We want to maximize our pre-oxygenation and patient positioning. We'll go through this in a little more detail. So when we're pre-oxygenating, our goal is to increase oxygen set to 100% ideally, and even more so is to remove nitrogen from the lungs and increase oxygen in the alveoli. In a normal, healthy individual, we have about 450 mils of oxygen on room air, and with 100% FiO2 pre-oxygenation, this can increase to 3 liters. And this essentially increases our safe apnea time. And so at the bottom of the slide here, you can see that in healthy patients who've been pre-oxygenated, they can go 6 to 8 minutes before desatting below 90–95%. And in a healthy obese patient, this is about cutting half to 3 to 4 minutes. But in the critically ill obese patient who's working hard to breathe and consuming more oxygen, they can desat within less than a minute. And another reason for this is we often can't get their oxygen set above 90%, and they're on the oxyhemoglobin dissociation curve. Once you get into the 80s, you're approaching the steep part of the curve, and we've all seen those patients go from in the mid-80s to 20–30% in a matter of 20 seconds. So in pre-oxygenated, we use high FiO2, more so in obese patients. You want to try to increase their airway pressure using CPAP or a PEEP valve, try to pop open the lungs. There's been a number of studies looking at this, showing that it extends safe apnea time about a minute. Elevate to the head of bed, we'll talk about more. And there's been studies that show that time to desat also is longer when you're sitting up compared to supine, about 400 seconds when sitting up versus 280. And then apneic oxygenation has been in the literature for some time, but I think it's more, over the past few years, there's been kind of a push in emergency medicine literature. And the concept is that alveoli continue to take up oxygen even when they're apneic. And some studies from the anesthesia literature looking at nasal cannula oxygen have showed that time to desat is increased to about 5.5 minutes from 3.5 minutes. And so we'll often use nasal cannula oxygen now, crank it up to 15 liters, and keep it on during pre-oxygenation and with attempts to intubate. Vague valve mask ventilation is the main rescue device in RSI, but it's much more challenging in obese patients. Mask doesn't fit as well on the face, and just given the poor chest wall compliance, it's hard to push air in against the heavy chest and against upper airway resistance. So there's a number of adjuncts we can use to try to maximize our success. Putting in 2 nasal trumpets and an oral airway can move some of the soft tissues out of the way and displace the tongue anteriorly. And using a 2-person technique, 1 person holding the mask and doing a jaw and chin lift, and the other person ventilating, sitting the patient more upright, and using a PEEP valve. And if, despite all these other methods, you still can't ventilate, switch to a supraglottic airway. So positioning is a big thing with any intubation, but I think even more so in obese patients. This often isn't, we don't really think about this, but sitting the patient up, taking some of the weight off the chest, taking some of the weight off the belly, and allowing the diaphragm to relax more. And this can increase or decrease their work of breathing, prevent some of the atelectasis that develops. In a trauma patient, it's a little more challenging because of spinal immobilization. You can technically do reverse Trendelenburg in those cases, and then the ear to sternal notch technique that we all learned to improve the view to the trachea. So some of the techniques that we go through or we use, RSI is kind of the mainstay versus awake intubation. There's a number of advanced airway adjuncts that we use, video, laryngoscopes, fiber optic intubation, bougie assisted, supraglottic airways, and then surgical airways. And as I talked about before, I was kind of thinking through your next backup. So going just briefly through this. In awake intubation, this would probably be one of the more ideal settings, although it's not often done in the ED, especially in a critically ill patient. The benefit is that you can minimize the risk of desaturation. Patients can maintain their spontaneous respirations, but it requires patient cooperation. It's not very easy in a trauma patient who has spinal immobilization. There's a number of videos on YouTube you can watch people intubating themselves doing this technique. It doesn't look very comfortable, but you can use lidocaine nebs, viscous lidocaine. Some people inject lidocaine into their trachea, and then assisting with fiber optic or VL. RSI, as I mentioned, is kind of the mainstay for intubation, and this really optimizes our first pass success, paralyzing the patient, sedating the patient, and we use the CMAC downstairs, but there's a number of other video laryngoscopes that can help increase visualization of the larynx and decrease time to intubation, and I think even more so allow everyone else to kind of watch and make sure the tube is not going into the esophagus. And then bougie can help facilitate placement of the tube. And then kind of at the end of the airway algorithm, when nothing else is working, you can't intubate, you can't ventilate, then you move on to a surgical airway. We all learn how to do this on mannequins or cadavers. Unfortunately, the patients that we often will need to do this on is a crashing patient who has very poor anatomy and not very easy access. They have obese patients have obscure landmarks and short necks, and so if you're concerned enough, you can prepare the neck in advance. You can consider ultrasound to help locate the cricothyroid membrane. There was one study looking at this that I found physicians trying to identify the cricothyroid membrane by palpation, and it said 24 physicians. I'm not sure why there were 7 OB residents, but in this case, they did not identify the cricothyroid membrane in any obese patient with a BMI over 30, but also only in 10 of 40 in the non-obese. This is an ultrasound picture of the cricothyroid membrane. You can practice it downstairs on a more lean patient, but you can see the thyroid cartilage with some shadowing behind it, and the cricoid cartilage membrane between the two. So moving on to ventilator management, I think the important thing here is to remember tidal volume. 1% ventilation, we all spit out 6 to 8 mLs per kilogram, and this is based on ideal body weight. So to give you an example, we have Sam Stelfcook here, who at his ideal weight is about 220 pounds. Now, Sean Bully, unfortunately, took him out during the residency versus faculty football game, rupturing his patellar tendon, and he now has put on a significant amount of weight. So he's approaching 500 pounds now, and when he comes in aspirating on his McNuggets, remember his lungs have not increased in size despite his body hardness. The other thing to remember is to use a higher PEEP on these patients, 10 to 15 centimeters of water, pop open the lungs, promote recruitment, but being cognizant that you want to keep their plateau pressure down below 30 if possible. Briefly talk about abdominal compartment syndrome. Obese patients are at a higher risk of developing this. They have intra-abdominal hypertension at baseline. ACS is intra-abdominal hypertension with organ dysfunction. It's becoming more increasingly recognized, and there's a higher morbidity and mortality associated with it. And like I said, there's an association between elevated BMI and intra-abdominal hypertension. So at baseline, they're predisposed to potentially developing ACS. And there's a number of other physiologic derangements that develop from this: respiratory derangements and cardiovascular derangements. So if you're concerned enough, patients intubated in the ICU, you can measure bladder pressure with a Foley catheter. Normal is less than 10 millimeters of mercury, and intra-abdominal hypertension is in the 10 to 20, 25-ish range. And then once you're above 20 to 25 with signs of organ dysfunction, consider to have ACS. And then talking to the surgeons, trying to figure out best management options, whether it's surgical decompression, or trying to remove some fluid from the belly, or putting an NG in or a rectal tube. Vascular access, as I kind of mentioned, is very problematic in these patients. We have great nurses in the ED who can seem to put IVs in anything, but you often can't even visualize peripheral IVs, so using ultrasound can help facilitate that. But in a critically ill patient, you shouldn't waste time trying to get an IV and go right for an IO. And then central access is always an option. Sometimes we have to put those in when nothing else is working. Imaging, portable radiographs are of poor quality. I feel like this is commonly seen on a lot of radiographs, limited due to body habits in more and more frequency. And then advanced imaging techniques, CT and MRIs, have limitations as well due to weight restrictions and size. There's a patient when I was a med student who we had to send to the zoo for a CT scan. And then ultrasound has limitations as well. The waves are attenuated by fat, and they have poor resolution. Some of the procedural changes, we all know about needle thoracostomy. Basically, the shorter the catheter, the standard catheter, 3 centimeter catheter, is unsuccessful in most patients. And so if you're going to do this, use the longer catheter, 4.5 centimeter catheter. And then central lines, I've had a few patients where the 2.5 centimeter introducer needle is too short, and I've had to use a spinal needle to advance the guide wire. And chest tube may need a longer incision just to facilitate movement getting into the rib cage. And then we already talked about cric. So a number of pharmacologic considerations. These patients are at increased risk of under or overdosing medications. And meds generally are based on ideal body weight or total body weight, which unfortunately is becoming 2 separate dosing regimens. As a general rule, lipophilic medications use total body weight, and if it's hydrophilic, use ideal body weight. Main thing is just remember to look it up and use your pharmacist for assistance. You don't really need to go through this, but these are some of the meds we use in the ED for intubation and some other dosing. Just briefly on trauma in obesity, there's some literature looking at blunt trauma and shows that they have a different injury pattern for whatever reason, but there's a higher risk of injury to the thorax and extremities and lower risk of head injury. And then there's some conflicting data on mortality, and some of the older literature has found that obesity isn't necessarily associated with worse outcomes, but that newer literature shows a higher mortality. There's a number of nursing challenges. Physical science complicates even basic interventions, wound cares, facilitating movement of the patient, and these patients are at significant risk of immobility, developing pressure sores, pressure ulcers, so we may need to use different kinds of air mattresses, and just increased risk of injury to the provider. So back to the original case here. Josh, what would you do in this situation?
So I think obviously ADCs, they're combative, agitated. The big problem here is access too, so I probably want to start by, if you want to go down your ADC's pathway and intubate this patient to facilitate exam and further studies, you probably want to place an IO. That's probably where I'd start and go from there.
Yeah. And I think this is challenging for a number of reasons, but I mean, getting the access, like you said, I think one of the big issues too is the agitation and hypoxia, and how are you going to manage that if you're trying to pre-oxygenate, get the oxygen stats up higher. A lot of our medications that we use are respiratory depressants and can significantly worsen his respiratory status at baseline. So this was a patient I had as a medical student, which didn't end up going very well, but essentially, they got an IO and they couldn't pre-oxygenate the patient. They were giving some benzos and tried to intubate the patient, really desatted, and had a hypoxic arrest and coded. So just some things to think about. I think if I were doing things differently, I mean, there's other options. I know ketamine is controversial with the possibility of head injury, but I think that's a medication we often use for agitation in patients and can help facilitate maybe pre-oxygenation. So just some take-home points. When you have a critically ill obese patient, remember they have pretty poor cardiopulmonary reserve. Keep a close eye on them, monitor them, and get IV access early. Consider difficult intubation and optimize your pre-oxygenation and positioning. Consider abdominal compartment syndrome, and then medication dosing discuss with your pharmacist. Any questions?
When you're thinking of the obese airway, I just think of, is there anything different that we have to keep in mind with an LMA? These big, or can we just use an LMA like we always use an LMA?
I think I just use an LMA. I think you may have to downsize potentially, but I just would go for the standard size, unless RJ has any thoughts from the EMS literature, but in general, I would just go for the standard size.
Nothing different. You might need actually a larger size too. But we tend to use King steels, and they come in 4 different sizes. I think the head injury thing has been pretty much defined with ketamine.
Yeah.
And the other possible approach, and this may be what you were referring to, is delayed sequence innovation, where you would give the patient ketamine to not take away their drive while you're